Medurstand-Understanding Medicine.
I'm Professor Aziz Rehman, and if you have landed here directly, I suggest that you should go through the first part of the same topic, community-acquired pneumonia. And if you have already watched that video, you're welcome to watch this one. This is the second part, and this would cover the prognosis and the treatment part of the community-acquired pneumonia. Now, prognosis, pneumonia is a relatively serious condition. So it is a serious condition, and we can judge from these two scoring systems. Any clinician would have fairly good idea from the overall clinical picture, but if you want to follow a certain specific system, these are two systems, curve 65 and port. And I'm going to go through these two systems very briefly to let you know how to score, how to judge the severity in these patients. This is curve 65. Curve C is for confusion, U is for urea level, and R is for respiratory rate, and B is for blood pressure, and age is an additional feature, 65. So more than 65. So the curve 65 means these four features plus age above 65. So if somebody has confusion, 1, urea more than 20, 1, respiratory rate more than 30, 1, and blood pressure less than 90 or less than 60, 1, and if age is more than 65, 1. So this would make total of 5. So depending upon what score you get, you would be accordingly labeled as serious. So these two would probably be less serious, and these would be very serious. This would be in the middle. And those who score the 0, they would have very good prognosis, and they can be managed at home. Now this is the QR code of the same app. If you want to follow this, you can just scan this, and that will lead to the website, and you can do the scoring there. Many authors, they feel that this U should be taken off because this requires a laboratory test. All other are just clinical features. So if you take off this, then you can score the patient out of 4. Now there is another more elaborate scoring system, and this is called PORT system. PORT is Pneumonia Outcomes Research Team, and this is much more elaborate. So I will again try to be as brief as possible. There are 4 components: demographic factors, comorbid illnesses, physical examination findings, and laboratory and radiological findings. So based on these, all components have then further components, and I'll just show you how you score this. So the first demographic factors, if somebody is male, you just count the age, but if somebody is a woman, then you count the age minus 10. That means women for the same age tends to have better prognosis. So they have the advantage. If 50 years man and if 50 years a woman is likely to have better prognosis. Then those who are nursing home residents, they score 10. That means they have a poor prognosis. Second component, comorbid illnesses. Now, if patient has got neoplastic disease, any neoplastic disease, not necessarily related to lung, any neoplastic disease, he gets 30 marks, liver disease 20 marks, congestive cardiac failure 10 marks, CVA 10 marks, and renal disease another 10 marks. So whatever this patient may have, 1 or more, the points will be added. So that will make the prognosis more and more serious and worse. On physical examination, now if somebody has altered mental status, he gets 20. Of course, you have to see that it is not due to another thing like patient has not been medicated. So altered mental status 20, respiratory rate more than 30, 20, systolic blood pressure less than 90, 20, temperature less than 35 or more than 40, 15, pulse rate more than 125, 10. So all these parameters, the clinical parameters, they would indicate serious prognosis. So they can all be measured on bedside based on your clinical examination. And finally, laboratory and radiological findings. So pH less than 7.35, 30. Patient with pneumonia is likely to be hyperventilating, and due to that, patient is likely to have an alkaline pH, and this is slightly acidic pH. So if the patient is slightly acidic, that would mean impending respiratory failure. So there are 30 marks, blood urea nitrogen more than 30, 20 marks, sodium less than 130, 20 points, glucose more than 250, 10 points, hematocrit less than 30, 10 points, arterial blood gases, partial pressure of oxygen less than 60 millimeter of mercury, 10 marks, and presence of pleural effusion, 10. So this looks like very complicated, but if you're specializing in respiratory diseases and if you are handling patient with pneumonias as a specialist, I think this would be much more relevant. But at least for internists, this should give you a concept how to score and how to judge which parameter would indicate relatively poor prognosis. So this is actually the summary. Now I don't want to go through this entire thing, but this is the summary of all 4 components, and based on that you will score them. So you could have any number. For example, people who have this risk, we can then classify into 4 or 5 risk groups. Risk group 1 and 2, those who score less than 70, their mortality is very low and they can be very effectively safely treated as outpatient cases. Now this will save hospital resources and this will also save patient resources, and it would also be convenient for the patient and the family. And those who score more than 90 up to 130 or more, they need to be treated in the hospital as inpatients and ideally in high dependency area, or some of them might need actually ICU care. Now this group 70 to 90, they could be treated as OPD or as inpatient, and one intermediate approach is that these patients can be treated with injectable antibiotics but at home, because nurses may be available at home. This will save hospital resources. So if the category changes, then of course our plan would also change. Patient at this category later on becomes more sick, goes to this category, then of course at that point of time he would or she would require hospitalization. So this again is available if you scan this QR code, and that will lead to this page, and then you can do scoring on the web. So it's a complications, it's a serious infection and it could lead to complication. There may be pleural effusion, we call it parapneumonic pleural effusion, which may be just sterile, an immune response, inflammatory response, or it could be actually pus. In that case it is called empyema. If you take the fluid out, you will know this would look like just normal extracellular fluid, straw colored, and this would be like pus. Lung abscess may be formed, septicemia and shock, which is a very serious condition, including endocarditis. It could be respiratory failure, and unfortunately in some cases it could lead to death. So all these complications are possible, and they would be more common if one scores high on those scoring system and if the treatment provided is inadequate. And so I think we have to provide the best possible treatment because it is a potentially serious disease. So treatment, I think very important. It is one infection where antibiotic is definitely needed. I must confess that on the part of our profession, that in majority of the cases with the respiratory infection, antibiotic is prescribed, though it is not needed. But pneumonia is one condition where not giving an effective antibiotic is asking for trouble. So I think we must give a prompt, good dose antibiotic. And what antibiotic, that would be based on your empirical judgment, and later on optimized by the blood culture, the sputum culture. So I think antibiotics, you could use any of the three. Since in many patients, it is not possible to 100% confidently differentiate between pneumococcal and mycoplasma. So I think it is a common practice to cover both. So to cover pneumococci, we can give amoxicillin 1 gram 3 times a day, oral or injectable, or we could give amoxiclav 1 gram 2 to 3 times a day IV, or same dose, twice a day orally. So this would cover pneumococci. To cover mycoplasma and to have additional cover against these, I think clarithromycin 500 milligram 3 times a day or azithromycin 500 milligram twice a day would be a good choice. And as an alternate, we could give moxifloxacin or gefloxacin or garifloxacin or levofloxacin or sparfloxacin. These are respiratory quinolones. Luckily, these respiratory quinolones are very, very effective, and they cover both gram-positive pneumococci and these mycoplasma. By the way, why amoxicillin and amoxiclav does not cover mycoplasma? Because these antibiotics, they work on the cell wall, and the mycoplasma or the atypical organisms, they do not have cell wall. So these antibiotics will not be effective. And moxifloxacin, another respiratory quinolone, they have intracellular action. They work on what is called DNA gyrase or DNA gyrase. I don't know how to pronounce, but I call it DNA gyrase. So it works on that, and it would be effective in both types of bacteria. So I think one single antibiotic would be sufficient. Although lately resistance to these antibiotics have also been reported. Resistance to amoxicillin is fairly common, but resistance to moxifloxacin has also been reported. Typically, moxifloxacin would be started as 400 milligram intravenous. We can start with intravenous, and later on we can switch over to oral. Luckily, moxifloxacin has what we call IV oral bioequivalence. That means the effect of oral administration, same dose, would be expected to be the same as that of intravenous. So that is a great advantage. That means patient is hospitalized, we have started intravenous therapy. Once patient gets better, patient wants to go home, we can switch over to oral, same dose, same antibiotic, and patient can complete the rest of the antibiotic course at home. So that will be an advantage. So that is why mostly, and these antibiotics are also better tolerated than the first line. So I think in my practice, I usually prefer these antibiotics as first line therapy in these patients. There are many other options depending upon the community, and of course I cannot cover all those. So then supportive treatment has to be given. Patient with high fever, we need to give them antipyretics or do sponging, analgesic to relieve their pain, antitussive to relieve their cough. So this kind of supportive care. And then of course treatment of complication. Those patients who are sick, they need to be hospitalized, and we have to monitor their vitals, and if they develop any complication, we have to treat them. Patient with pneumococcal pneumonia can also develop an endotoxic-like shock. This is because of the polysaccharides present in pneumococcal wall. So the clinical picture will be exactly like of endotoxic shock. Patient may go into severe hypertension. So a good physician would anticipate these complications and will take a prompt action when they develop. So how do we prevent this serious complication? It's a serious complication. I think a good personal hygiene. You should maintain good hydration, and you should avoid getting exposed to poor quality air, and protect yourself during harsh winter season, and wear mask if you have to go to these areas. And pneumococcal vaccine is considered to be very, very effective. It may not be indicated for all, but those patients who are at high risk, like patients with existing lung diseases, people older than 65, people with diabetes, people with asthma, chronic bronchitis, people with HIV infection, and people without spleen or some other hematological disease, all of them should receive pneumococcal vaccine. one injection of this conjugate polysaccharide vaccine 13 valent is effective many times for life, but sometimes we have to repeat it after 5 years. So this is very, very effective. This would be in addition to annual influenza vaccine. So that brings me to the end of my presentation. I hope this was useful. This was a 2-episode presentation. I hope you have taken away a good concept of community acquired pneumonia, how to diagnose, how to treat, and how to deal with complication. This was Professor Aziz Rehman from Medurstand-Understanding Medicine. Thank you.